I can probably start with the introduction. I think I don't have to introduce myself. Because we had no external speaker, I thought I'd jump in and serve as a speaker for the Grand Rounds in February and give you a little bit of insight in work that I have done in my times when I was in Germany. And of course, we have patients like this here as well. But we don't use imaging in neurodegenerative diseases as often as we, I think, should use. The title is MR imaging, but you will see also some CT images. And the presentation is actually to show what happens with the brain and spine if there's a degenerative process going on. Well, I think you know this person, and clearly he has some degenerative, neurodegenerative disease for different reasons than most humans, but it's clearly visualized on this skull X-ray, which we don't do, or which we should not do in degenerative diseases. That's outdated. So let's talk more about the diseases itself. So what is a neurodegenerative disease? So what is the definition? Per definition, it's a condition in which cells of the brain and spinal cord are lost, and there are different reasons why they are lost. It's very small here. So I have to give me 1 second here. I don't know why it's very small here on my screen. Okay. Yeah, so when cells of the brain and spinal cord are lost, this causes then clinical deterioration, and we experience symptoms at one time. So we have dysfunction and disabilities, both coming from the brain as well as from the spinal cord. And here you see a little bit of the outline of my presentation. So I will talk a little bit about the clinical presentation, then neuroimaging findings using different modalities, and then you will see also a little bit of correlation with what we found on a molecular level if the cells are dying. In general, clinically, we differentiate degenerative diseases of the brain and spinal cord into two main groups based on their clinical presentation. They can result in a movement disorder, so patients experience problems with their movements, with the mobility. And there are a few diseases like Lee's disease and Wilson's disease that mainly present with changes in the movement. And then there's the large group and more dominant group of the dementing disorders. So it's not that patients experience some changes in their movements or in their mobility. They have mainly a cognitive problem. So there's a cognitive decline that can be fast or can be very slow. And the majority of the neurodegenerative diseases actually present with dementia symptoms. The most common one, of course, is Alzheimer's disease, but there's quite a large group. And then there we have an overlap. That's diseases where we have both dementing or dementia or cognitive decline, as well as some movement changes. And depending on what kind of disease, either the dementing disorder comes first and then the movement, or vice versa. So looking at degenerative diseases over the last years or the last century, they are becoming more and more, or we are becoming more and more aware that there are neurodegenerative diseases. And one of the main issues is that in a lot of those diseases, the main risk factor is age. And if you look at our population and the distribution of the age groups within our population, especially in the Western world, we see that we have a dramatic change. So whereas in the past we had majority young individuals and the average life expectancy was lower, so a lot of patients didn't even reach the age to develop a neurodegenerative disease. This has changed over the years, and now we have an overrepresentation of elderly subjects in our population, and therefore we see more and more neurodegenerative diseases. That has also resulted in the definition of what is an old subject. Like if you would have asked some psychiatrists about 50 years ago, they would have said probably an old subject is one in its mid or late 60s. Now they are talking of an old subject, someone in the mid or late 80s or even more. And the amount of people that reach the age of 100 is increasing year by year, especially in the Western world. So we do expect to see more and more degenerative diseases in our population. And neurodegenerative diseases, they go along with changes in morphology and function. So what is the role of imaging in this whole scenario? So we do see more. They are more present in the population. There are more and more people that are also known people in, like celebrities, that develop neurodegenerative diseases. Mainly Alzheimer's disease is very popular to be reported of. So what is the role of imaging? There are multiple roles for imaging in neurodegenerative diseases. So we can visualize changes in the morphology, and that's what I would like to outline in my presentation. We are also able to see changes in the function of the brain and spinal cord in some degree. So the main topics and that's very complex scenario, what is really the role of imaging, because there's not a single role, there are multiple ones. Well, first of all, there are some treatable causes of a neurodegeneration. So there are some diseases which can be treated, and we have to identify them. And a lot of them are best identified using imaging studies. I will come back to that in a minute. Then we have to provide a differential diagnosis that may help in the treatment if a treatment is available. This differential diagnosis we can only give if we are able to define what is normal for a certain age group. We have to delineate specific changes in the brain. If there's an approach for a surgical intervention, for example, or for a radiation therapy, then we have to help them with the approach and the treatment planning. We have to monitor for complications based on treatments, and then we can, if there's treatment available, provide treatment monitoring. So it's a very complex scenario where imaging can be used in neurodegenerative diseases, and it can be sometimes very difficult, which I would also like to outline. So a couple of secondary causes. Here you see two patients. They were both admitted to the Center for Mental Health with dementing symptoms. So they developed a dementia. They came into the psychiatry hospital. That's where most of the patients had their workup, at least at our side and also here. And we found, of course, some treatable causes, like that one patient here had a large frontal tumor. Turned out to be a meningioma, was resected successfully, and the dementia completely resolved in that patient. The other patient here on the right side, that's a patient with a normal pressure hydrocephalus, or an enlargement of the internal ventricular system, a discrepancy of the width of the inner and outer CSF spaces. So there's an increased pressure in the brain, and if you release that pressure by, for example, an extra, like a drainage via shunt, then you can resolve the problems. And in a hydrocephalus, dementia is one of the main symptoms of that triad, which is movement disorders, incontinentia, and dementia. So both patients could have been treated and their symptoms resolved. Others are tumors, bleeding, and normal pressure hydrocephalus, as I said. That's another patient, was a younger patient in early 60s, also from the psychiatry outpatient clinic, admitted or presented there with dementia. And that patient had a large frontal tumor. This was not a benign tumor, that was a malignant tumor, glioblastoma. But after surgical resection and debulking of that lesion, the dementia symptoms completely resolved. But of course, the patient had other symptoms and finally died from this disease. Another patient here, that's an older patient, again, a large, in this case, extraaxial lesion. So a meningioma again, after successful resection, complete resolving of the dementia symptoms. It's in the majority of cases, tumors in the temporal lobe or the frontal lobes, depending, of course, of their size and which which hemisphere they are, patients can present with dementia as the primary symptoms for this kind of a lesion. So the normal pressure hydrocephalus, that's a common question that we have, like a patient has mental decline, and we do a workup with an imaging study. It's mainly done by CT as the first diagnostic test, also because of the availability and the costs. And then we have a diffuse ventricular enlargement. There's stretching and bowing of the corpus callosum. If you look at the sagittal scan, there's a discrepancy between the width of the inner and the outer CSF spaces. And we do have the so-called cap signs, which is an ependymal or subependymal CSF flow, which you can see here along the frontal horns and the posterior horns of the lateral ventricles. And if you find something like that, of course, you have to flag it, so because this is a very easy to treat disease, and in most of the cases it works. There's a little bit of a discrepancy in the literature where it's discussed how long a normal pressure hydrocephalus can exist and how long a patient can be successfully treated, and there's a large discrepancy, so like at least you should try to treat those kind of changes, but it's not resolving in all of our patients. So talking about degenerative diseases, what happens if there's a degeneration in the brain? What are the changes that we see? Sometimes it's very difficult to really find it based on the clinical exam because, like, of course, these two fellows, they have a different iron content in the brain. They have a different parenchymal volume, and they have different white matter, but well, their performance in their like movement and probably also their mental performance can be quite different. So iron content, parenchymal volume, and white matter, those are the three that change the most over age in the brain. And so we look, if we do an imaging study, we look at the parenchymal volume. So we grade and in some cases also quantify the amount of volume loss, atrophy. Then we look at white matter changes, which are most sensitive seen on T2 or flare-weighted images, so-called T2 hyperintensities. And then we look at the iron content. But the iron content is not so easy because iron we cannot really directly visualize. We see it indirectly because iron causes a susceptibility artifact. So it disturbs the local magnetic field, and therefore we don't see signal in that area. So where iron is present, we have normally less signal or low signal. And that, of course, depends very much on the amount. It depends on the field strengths we are using. It depends on the sensitivity for susceptibility of the sequence we are using, and so on and so on. But there are certain MR sequences that allow us to quantify or even more semi-quantify the amount of iron in the tissue. Okay, looking at the scenario of aging. So from a clinical standpoint, it's important to differentiate, and also from an imaging standpoint, it's important to differentiate between atrophy and normal findings and correlate that with normal aging or pathologic aging. So if we have a normal aging, we of course do see some white matter changes. It's almost normal to develop some white matter changes in the brain, but it can be still successful and the patient has no clinical symptoms, so normal findings. There's also normal aging where we do see, we call it usual aging, where we do see some atrophy and where we do see some white matter changes, but the patient does not present with clinical symptoms. So it's still a usual aging. And then we have, of course, pathologic aging, where we have pronounced atrophy and where we have pronounced white matter changes and where the patient presents with clinical symptoms. And of course, you can imagine there's a large overlap in our population. And in a long-term clinical trial, which I was part of, we looked at that, and we looked at that in a very systematic way. So we had 500 subjects, 250 from East Germany and 250 from West Germany. And they were from the year 33 and 53. So we had pre-World War II subjects born before World War II and subjects born after World War II. And then we had the two areas in Germany because there was different nutrition, different education systems, and so on. And we followed those patients, or we do follow those patients now for more than 20 years with MRI. And they get imaging studies in certain intervals, they get a clinical assessment, they get lab tests, they get CSF testing, and so on and so on. And it's very interesting what we find. And it's, well, the most impressive finding is the large variability of those patients. So this is from one of the follow-ups when they were, that's from the cohort born in 1933, when they were 71 years old. And those are all subjects that actually were identified in that cohort. The patient on the right had some minor cognitive changes, but not a dementia. So only some minor changes. But the two on the left, they were identical clinically. And here you could see that there's clearly a different degree of atrophy. Here on the left-hand side, there's no atrophy at all. So this is a patient with a successful aging. So we don't see much of atrophy. We don't see a lot of white matter changes. In the middle, we have probably still a usual aging. So we do see some atrophy, and we do see some white matter changes. I will show you the upper slices later on. And here on the right-hand side, that's from an imaging study, a pathologic aging, because we have more than normal atrophy. And we do see more white matter changes. And you can even see here some Wallerian degeneration already in the pons. So there's an interesting study that was published quite a while ago in 2007 from Sullivan. And he did about the same analysis, but not a longitudinal. But he looked at different age groups. And he tried to quantify the amount of atrophy. So structural imaging was done in normal subjects. They subtracted the images and looked at the brain parenchyma and an enlargement of the sulci and the ventricular spaces with aging. And you see here the three groups, like the 21-year-old, the 53-year-old, and the 71-year-old. And you can clearly see that there is, and that's matched, that's not an individual, it's kind of multiple brains morphed into one other. And you can clearly see that there is atrophy that takes place with age. So we have to be aware our brain is shrinking over time. But looking in detail, where's the majority of the atrophy taking place? And it's actually taking place in the cortical gray matter. So that's what we lose. We lose cortical gray matter, whereas the cortical white matter, or the subcortical white matter, remains fairly stable over the different age groups. And that's probably a key to differentiate between normal aging and pathologic aging, because we do see differences also in the cortical white matter in a dementia patient, for example, whereas we don't see it in a normal aging. But as you can see, just from the dots, there's a huge variability in between the individual subjects. So we do see mainly in normal aging gray matter atrophy. The white matter atrophy is less than 2% per decade. And very important, and that's what we used also later on to better differentiate between normal and pathologic aging. The corpus callosum is a very stable piece in the brain with only less than 1% decrease in size per decade. We do see sulcal expansion and uneven cortical surface just because the brain overall is shrinking. And the problem was for the normalization that there's a large overlap in between the subjects. Looking at the white matter changes, those are again the three subjects you have seen before. They are all 71-year-old, all from the same area. Like it's not that they did grow up in different areas of Germany, not east or west. They are all from the western part of Germany. And so this is the 71-year-old that has no white matter changes. There's only a single dot was seen. This is what we more likely see in 71-year-olds. So the question is, this is still usual? can be debated, like it's already quite a substantial white matter changes. And here that's definitely pathologic. And the patient not only had normal small vessel ischemic changes, we also see some old lacunar infarcts with proencephalic defects. There's an enlargement of the lateral ventricle based on this proencephalic defect. So this is pathologic for sure. So the white matter lesions, we do see them in a lot of subjects. They are increasing with age. And in our reporting, what we assess, we talk about the size, the shape, the location, and the absolute number, or whether they are confluent. And of course, we have to correlate them with the patient history, like does the patient has hypertonus, diabetes, or other diseases that increase vessel ischemic changes. There was a grading system proposed a couple of years. Not all of us are using that. I'm using it most of the time. So we have in grade 1, we have solitary dots. They are not confluent. Then in grade 2, they are more confluent. Grade 3, that's like encephalopathy. So we have larger areas of the white matter that are replaced by gliotic changes based on the small vessel ischemic changes in the tissue. What goes parallel to some of those, and I will come back to that later on because it has an impact on the treatment of subjects, is that parallel to the white matter changes, we find also microhemorrhages, especially in early stages of dementia patients. We do see them, and they are often correlated with either the underlying disease like hypertonus. With hypertension, we can see microhemorrhages within the tissue. They are more centrally located, like around the basal ganglia in the posterior fossa. But if we do see them in a subcortical location, they are often correlated with disease which is amyloid angiopathy. Like amyloid is deposited in the subcortical white matter, mainly in early Alzheimer's disease stages. And then there's an angiopathy which can be triggered by that amyloid deposition. And so the small vessels become weak, and we do see small hemorrhages. So it's not a mass bleeding, but it's small microhemorrhages, which we can see. And that's a dilemma in patients that have a hypertension, that have small vessel ischemic changes. They have probably some other vascular changes. So the key question comes up, is it still good to anticoagulate them? Because with an already weak vessel, the risk of bleeding is going up. And there's still a debate on until how many small vessel ischemic, or also until how many microhemorrhages do we really anticoagulate our patients? So where's the balance? Or what kind of anticoagulation should we use in those kind of patients that have already hemorrhage? The white matter lesions have to be differentiated from normal perivascular spaces, the so-called Virchow-Roman spaces. They are also common. Those are small CSF spaces surrounding the vascular structures, mainly in the basal ganglia, but they can appear everywhere in the brain. And of course, with aging, they appear to be more prominent because there's brain volume disappearing, and that's replaced by fluid, and that happens in the outer, in the inner CSF spaces, as well as in the perivascular CSF spaces. So they increase in size with age. They are found in a large number of adults, and even in pediatric subjects we can see them. They are commonly in the basal ganglia, and they become larger with age. They can appear everywhere in the midbrain, in all white matter areas. And the function is not clear, not fully understood, but what they discuss is production and absorption of CSF and some space for macrophages. So here are a few perivascular spaces. That's the typical ones that we see normally in the basal ganglia, but they can be everywhere. They can be symmetric, they can be asymmetric. As I said, they can be present in all age groups. Talk a little bit about the iron in the brain. So iron deposition, like is increasing with age. So the older we are, the more iron we have in our brain. Iron itself is a toxic substance, so it's also a discussion about how much iron is still normal and when does it start to become pathologic, and what is the role of iron in neurodegeneration. So here are two subjects, 72 and 69-year-old subjects scanned at a 3 Tesla scanner. So it's, if you want to compare the iron deposition, you always have to know what kind of scanner they are scanned on, or if you have a patient that is coming for a follow-up and now, you see there's so much more susceptibility artifacts in the basal ganglia, make sure that the patient was not scanned before on a 1.5 Tesla and now on a 3 Tesla, because it appears more prominent just because of the more pronounced susceptibility artifact. So it's very much dependent on the field strength. So here that's a 3 Tesla here, and that's a 1.5 Tesla scan. Calcium in aging, that's another topic. So we do see an increase in calcium over age. Calcium we don't see directly on MR. If there's enough calcium or calcification, we do see it also in MR, because then it causes susceptibility artifacts. It's seen more sensitive on CT, and it can be present in different diseases. So here's some physiologic bilateral symmetrical calcification in adults. And if it's a large amount, then we even see here reduced T2 signal. Another case here, but also in some cases, because if they contain a certain amount of fluid, then we can see them as a hyperintensity on the T1 weighted scans. So coming back to the individual disorders. So the most common one, as I said before, is Alzheimer's disease. So this is, by the way, Mrs. Data. She's the first Alzheimer patient ever described. Her physician was Mr. Alzheimer, therefore it's called Alzheimer's disease. And she came into the hospital in 1901 in Frankfurt. She, guess how old is she? She came from actually a normal family. So she was not a hard-working kind of lower-class woman. She was had 2 children, was living in a household with good nutrition and so on. But she was only 52 when she presented. So she was she looks aged even for that time, 1901, based on her living conditions. So Mr. Alzheimer described her quite well. Clinically, and it's very interesting. Like, I'm German, you know, and we are very well organized, but because her file was not stored in the 1901 files, it was stored in the 1931 files, it survived, because the ones from 1901 have been already destroyed. So it's actually by mistake that this patient file still exists, and it contains photographs. So Mr. Alzheimer did photographs, did record the interviews he had with her, and she was in a very kind of already progressed dementia. So it was not a minor cognitive impairment. She was really severely demented. But she still survived. She died in 1908. And by that time, Mr. Alzheimer worked already not in Frankfurt, in Munich. And he asked for her brain. So they sent him her brain, and the brain was autopsied by him. And he described the amyloid plaques and the neurofibrillary tangles, which is still today one of the main pathologic criteria for the diagnosis of Alzheimer's disease on a pathologic level. So he was very advanced that time in the description of that disease. So Alzheimer's disease accounts for the majority of dementia patients. It's about 65 to 70%, depending on the literature. Then there are some vascular forms of dementia, so mainly vascular triggered after multiple strokes. And then we have some rare forms and some mixed forms. And the mixed forms are normally the ones that are mixed Alzheimer's and vascular dementia. So it affects quite a large number of people worldwide. That's a little bit an older slice, so it's definitely more than 24 million. The main clinical symptom is short-term memory loss. The disease begins long before the symptoms come up, and minor cognitive impairment is kind of a precursor stage. And the duration of the disease can be very variable depending in what kind of conditions the patients live. Because patients with Alzheimer's disease have for a long, long time no motor function disabilities. So it's only their cognitive decline. And if they live in a very protected environment, so they don't have to take care by themselves, because they forget to take care about themselves. If they live in a home where they could get good care, they can live actually fairly long with that kind of disease. So up to 20 or even longer times are described. So what do we find histologically? And that's what actually Mr. Alzheimer described already in 1908. We do see amyloid plaques, and we do see neurofibrillary tangles. And we see them, of course, in autopsy cases or in biopsy cases. But we also have other markers, and the markers are beta amyloid and tau protein, and that's what we found, or that's what can be found in the CSF space. So every patient that has like a diagnostic workup for Alzheimer's disease normally gets an LP, and they look for beta amyloid and tau protein in the CSF. So in one of my last slides, I said that the disease is most active in the preclinical stage. It's pathophysiological active based on the levels that they measured for beta amyloid and tau protein. So these levels are highest at the very early stage or in the precursor stage of Alzheimer's disease. If you have a fully developed Alzheimer's disease clinically, the levels of amyloid and tau protein are already going down. So it's burned out already, the disease, and there's no more window for treatment. So important for us also, and imaging plays a role here, is to detect patients with higher risk for Alzheimer's disease or a neurodegenerative disease early, so as early as possible. So, but that doesn't mean that we need to screen all patients, but from a clinical standpoint, we need to be sensitive, and then a patient should undergo a diagnostic test early. So how does the disease spread? And that's data from a group in Frankfurt, neuropathologists that looked at brain autopsies in different stages of Alzheimer's disease and lengths. And they described the spreading of the amyloid plaques over time of the disease. So it starts here in the entorhinal phase, like medial aspects of the temporal lobe, hippocampus, parahippocampal gyrus. Then it spreads over the limbic system into the frontal lobes. And then in the late stage, it's the amyloid plaques and the tangles are present nearly everywhere. The corpus callosum is fairly stable over a long, long time, as well as the cerebellum. And both are important for movement. So patients have not a lot of movement changes in the early stages of the disease. So how do we measure those early changes? So what I said is that the medial aspects of the temporal lobe, that's where it starts. That's where the atrophy also starts. We can try to quantify that. There are different methods that have been described, like here by a group in Toronto, where we can measure really the thickness of the medial aspects of the temporal lobe. But what is done today more and more is that we look on coronal and 3D scans, and we see whether there's more pronounced atrophy at the temporal horns of the lateral ventricles compared to the general ventricular size. And then you can measure different areas here, like you can measure the width of or the size of the temporal horn and the adjacent brain tissue. There are multiple measurements, planar measurements that have been described. But what is used most often now in these days, especially from groups that are doing a lot of research and clinical correlation, is that they acquire 3D data with a contrast that has a good differentiation between gray and white matter based on the imaging study, and then they are able to quantify the hippocampus, the parahippocampal gyrus in relation to the total size of the brain, in relation to the total size of the temporal lobe. And this can be done not only for an individual, it can also be compared then with cohort studies, so where you have a larger group of normal subjects scanned on the same scanner. You can kind of normalize the individual data onto a larger database and then compare, like SPM is one tool that is used for that. And then you can see here, that's in Alzheimer's disease patients, you can see that the volume loss actually follows the amyloid plaque deposition. This can be shown in the follow-up, like that's a follow-up CT scan, and that shows you also how fast it can go. So that's not a long time in between those two scans, and you see that the atrophy was really very progressive. That's another patient here. That's MR used here, the coronal scans. That's from 2004 in March, and that's in October 2005, so 1.5 years later. You see that there's a significantly more pronounced atrophy evident. So you see the enlargement of the lateral ventricles, but mainly it's most obvious here that the temporal horns of the lateral ventricles have enlarged more than the rest of the ventricular system. So it's mainly a temporal lobe atrophy. This is another case, quite interesting. This is a 78-year-old normal subject, had no neurologic symptoms, but had a brain scan for, I can't recall for what reason, up here. But he came back with deterioration about a month later, and he presented with this scan. So you can clearly see, if you compare, there's an atrophy taking place. So what happened? Like, if you know the previous scan and that he was fully functioning before, you can estimate that, well, it's probably not Alzheimer's disease what is presented here, or neurodegeneration. So what happened, he was a very active fellow, and he played tennis in the sun without a hat for quite a long period of time. Might have been a long match on a hot day, so 14 days later. And it's just the volume loss, the fluid loss that caused that brain to shrink. And then he got a couple of bottles of water and returned to normal. That was a very interesting finding. So if you look at the early stages of Alzheimer's disease, this is again from our own data where we compared normal subjects, a larger cohort of normal subjects with Alzheimer's disease patients, so already Alzheimer's disease. You see that there is changes in the volume of the brain, especially where you expect the changes to happen, and that's in the medial aspects of the temporal lobe, and then spread over the limbic system into the frontal lobe and other areas. If you have an early stage of the disease, and those are now data from subjects with minor cognitive impairment, which is a stage in, like they call it, a precursor stage of Alzheimer's disease, because the patients are fully functioning, but if you test them with neuropsychological tests, they have deficits in a minimum of 2 of those tests. Based on longitudinal studies, we know that about 60% of those patients with those symptoms change within 3 years into a manifest Alzheimer's disease patient. But the changes are very subtle. If you look here in red, that's the significant different areas between the normal group and the minor cognitive impairment group. You see the changes are very small, and it's very difficult on an individual basis to quantify whether this is an atrophic brain, yes or no. It's almost impossible. So that slide should have come before. That's common finding of microhemorrhage in dementia. So it's more common to see microhemorrhage in early Alzheimer's stages than in the normal population. And the main discussion that is going on is that it's based on the amyloid deposition, the amyloid plaques, and they can cause later on also hemorrhage. So we have to know that. So at the end, let's talk about some functional imaging tools that can improve our diagnostic workup, because there's a difficulty, especially in the workup in early stages. And we do have a quite impressive armory of functional imaging tools that we can use in MR and in CT as well as in nuclear medicine. And I would like to share a few of them. Of course, nuclear medicine was used since a long time. Like we use FDG PET, for example, to differentiate between Alzheimer's disease that normally have very symmetric reduction of the tracer uptake compared to a vascular dementia that has more patchy and more diffuse changes in the uptake. And in recent years, there have been even specific tracers developed that specifically target the amyloid. So you can visualize the amyloid deposition in the brain. And they are now, the first of those tracers are now clinically available and can be used. So PET SPECT imaging can be used to diagnose Alzheimer's disease and also to predict hemorrhage. So this is one of those amyloid images, and you see that there's amyloid deposition in the subcortical white matter. And you see that this is the area where also the microhemorrhages are present and where this specific patient developed more like a macrohemorrhage. MR-Spectroscopy was used for a few years. It was mainly triggered by the insurance system in the US because for some reason the Medicare decided that they are reimbursing MR spectroscopy for the diagnosis of Alzheimer's disease. And then within a few months, everybody was using it as the diagnostic tool. And then they took it off the list of reimbursed procedures, and now nobody's using it anymore. So the role is not very clear. Because spectroscopy, first of all, is not so easy in those kind of patients because they're not the most collaborative ones. And we know that MR spectroscopy is very sensitive on motion and others. And it's also very sensitive for iron deposition. So in the areas that are really interesting, the subcortical white matter and where we have already amyloid deposition and microhemorrhage, we do see a lot of artifacts. So what has been described is that myoinositol is increased in the majority of Alzheimer's disease patients. NAA is going down. That's what we expect because NAA is a normal neuronal marker, so that goes down. And then choline, there were different reports. In some studies, choline was up, more membrane turnover, in others it was down. But that's from one of the largest series that I could find in the literature, is that we cannot differentiate between early stages and late stages. Perfusion was used for a long time also by my group. We did a lot of perfusion studies in the cohorts, like in normal subjects over time, using spin labeling technique as well as in Alzheimer's disease patients, then also with contrast-enhanced studies. And there was a reduction of blood flow in the frontoparietal area. So that's where the disease starts. So the underlying theory that we had is that you have a patient, you have amyloid plaques, and the amyloid plaques, they are close to the small vessels. So there's an impact on the small vessel and on the blood supply, and then we expect to see a reduced blood flow. And that's actually what was described in multiple studies. Like some of them are pretty old already, but especially in those areas where there's a lot of amyloid deposition, you see a reduction of the blood flow. What I think is the most promising technique in the workup of early stages of disease is diffusion tensor imaging. Diffusion tensor imaging that we know mainly for tractography has also more information in it. It has information about the integrity of structure or fibers. So whenever a fiber loses their integrity, the so-called fractional anisotropy, that's a quantitative marker that we can extract from our diffusion tensor imaging data, is reduced. So the area where we looked at in that first clinical trial, which is now rolled out into a larger clinical trial, is we looked at the corpus callosum. First of all, the corpus callosum is very stable in normal subjects, only 1% volume loss over a decade. But in Alzheimer's disease or in neurodegenerative diseases, we can expect to see a change because this is not a normal aging, that's a pathologic aging. And The other advantage of the corpus callosum is it has a lot of fibers, and it's a very robust, easy to study structure in the brain. So what we did is we divided 5 areas of the corpus callosum and calculated the fractional anisotropy in a very quantitative manner, extracting all partial volume effect, just focusing on the center of the corpus callosum. And we got very reliable results, even in raters or that are not very experienced in assessing those anatomic areas. And the variability within normal subjects was actually very low. So it's what I said before, a very stable organ with not a lot of loss of integrity over age. So, and then we looked at the patients that are coming out of our cohort, where we know and have the good clinical correlation, how they, all their clinical parameters are there, and we have imaging studies of them for multiple time points. And we looked at 10 of the patients that presented with minor cognitive impairment, and it was a prospective protocol. So 10 patients within the 3-year period changed into Alzheimer's disease, and 8 patients did not change into Alzheimer's disease. And we had another 10 patients plus patients as controls. So if you then quantify and look at the fractional anisotropy, the pattern of the FA values over the 5 different areas in the corpus callosum remains the same. But the red curve, those are patients that have already Alzheimer's disease, clinically diagnosed, histologically diagnosed. They had a loss of fractional anisotropy in all areas of the corpus callosum. The green patients, those are the ones that are normal subjects, so no signs of Alzheimer, not clinical, not in the laboratory. They have normal values. And if you now look at the 2 groups of minor cognitive impairment at the time where there still be minor cognitive impairment, you can see that the ones that did not convert within 3 years remain stable. They had the same pattern and values than the normal subjects, whereas the ones that changed into Alzheimer's disease had already the same values and pattern than patients with already Alzheimer's disease. So this is the only method that really reliably differentiated between patients that convert and do not convert into Alzheimer's disease patients. And that triggered a large national study where we not only looked at the corpus callosum, but also looking at the limbic system, which is a little bit challenged because it's a lot of data that has to be done. And it's now done in 3 countries, Austria, Germany, and Switzerland. So to conclude, I think even we are in the early stages and we are not using it as often, I think that imaging plays an important role in the diagnostic workup of patients with neurodegenerative diseases, mainly Alzheimer's disease. It is absolutely recommended not to let a patient with any psychiatric disease go home without an imaging study, because there are a lot of incidental findings. They might have to do with the disease or not. So I've seen patients that came with schizophrenia and had a brain tumor or some infection that was not diagnosed and so on. So imaging is a very important workup tool in a patient with a psychiatric disease, including neurodegeneration. Functional imaging studies like MR-Spectroscopy, perfusion-weighted imaging, and I think very important diffusion tensor imaging play an important role in the further differential diagnosis and better workup of those patients. What is important, or what are the challenges? The challenges is that the majority of our imaging studies that we are using today, they are just qualitative and they are not quantitative. So it's very difficult and challenging to compare an individual patient to a normal cohort if you don't have quantitative data. But that calls for robust measurement techniques and correlation with normal findings in a quantitative manner, and that's the most important requirement. And with that, I'm at the end. Thank you very much for your attention, and I'm open for questions.
Thanks, Dr. Essig. What about with with PET MRI, can you use the MRI data the anatomical data to improve the quantitative analysis from PET? Is there any
Yes, that's one of the topics that is currently investigated in a lot of PET MRI centers. Especially they are focusing on these early stages of neurodegeneration. First of all, to see long term, like in the initial workup, like how much amyloid is there, and how is the amyloid changing over time, and is it really correlated to the volume loss? So there's one interesting study which I was kind of indirectly involved because I was part of a radiology team that did the image evaluation of a study that was, from a clinical standpoint at the initial stage, very successful. It was a vaccination against amyloid that was used. And, but they had to stop it because they had major side effects, so even patients died from that study. So they stopped it immediately. But of course, the patients that were vaccinated, we did follow up them. And there are two interesting results. First of all, when the patients at the end of the observation period died and they had the brain went to autopsy, they didn't find amyloid anymore. So it was successful in respect of the vaccination. But the bad thing is that the patients still developed Alzheimer's disease. So they still develop dementia without amyloid plaques. So amyloid plaques, they play a role, but it's probably not the major role, and it's not fully understood what is really the role of the amyloid plaques. It's mainly, it started with Mr. Alzheimer as an observation. That's what he found in these kind of patients compared to others. But the role in the dementia process is not fully understood. But PET might help us.
Some of the treatments that are being given for early Alzheimer's drug treatments,
Yeah.
do those have any imaging correlates in terms of if the patient is either improving or the progression is slowing down?
Yeah. So there are imaging components in nearly all Alzheimer's studies. First of all, in the enrollment of patients, because they want to exclude major vascular components. So there's one study I'm involved is that it's the assessment, the pre-therapeutic assessment, whether there's a large vascular component, and that's an exclusion criteria because they don't want to have a mix-up. And then a lot of studies use quantitative MRI, just volumetric MRI in the follow-up of patients. So they want to see whether the predicted volume loss can be reduced by that kind of treatment. Of course, like the main assessment criteria is the cognitive function based on different and specified cognitive tests. But the second one is to see whether whether we can stop the volume loss over time. And there's some very preliminary data, but that's mainly done in very like phase 1 and phase 2 clinical trials where they use PET and now more and more amyloid PET.
But have they been able to show a decrease in the rate of volume loss that correlates with a decrease in the rate of progression of the clinical disease?
Yes and no. Like there was one study where the initial evaluation of the imaging didn't show a stop of the volume loss, but then they reanalyzed it, and then in the reanalyzing they found a change. Like they found that it actually was the volume loss was in the treatment group less than in the placebo group. But it's but that's the only study that I'm aware where it really showed that we can stop the volume loss. But if you look at the majority of study, couldn't even show that they can stop the disease on the clinical side. Yeah. And one of the main problems is that, as I outlined also, is that when a patient really becomes symptomatic, it's like on a molecular level, the disease is already burned out. So actually, the music plays before the patient becomes symptomatic. And that's a main challenge because they often come with already a very substantial volume loss. Okay, good. Thank you very much.